for the opportunity to speak here. I'm Windsor Ting. I'm one of the vascular surgeon at Mount Sinai. The subject of my presentation, Iliofemoral and Femoropopliteal DVT, expanding options for catheter-directed thrombectomy. How do I change this? Go to the next slide.
Just roll the roller. Yeah.
These are my disclosure. You can see the venogram on the left. This was a patient presenting with acute pain and swelling in her left leg. You can see on this venogram she has acute DVT in her left common iliac vein, external iliac vein, and also in the common femoral vein. You can also see there's a fair amount of collateral, suggesting probably there was a chronic component to this acute DVT, something that we see quite often. And after intervention is the venogram on the right side. You see restoration of flow throughout her iliac vein. Quite satisfactory outcome. There are numerous options that you can use to go from the venogram on the left to the venogram on the right. So the way I manage this patient in office has dramatically changed with the introduction of DOACs. In the past, I used to hospitalize the patient emergently for anticoagulation. I no longer do that. DOACs can fully anticoagulate these patients within a period of 4 to 6 hours and as an outpatient. And in fact, that is what I do frequently. So I anticoagulate them in the office setting. And then I go ahead and schedule the venogram, possible intervention, either the same week or in the following week. The only exception if the patient has very severe edema or major Dolan. And for just about all these other DVT, they can be treated almost on an elective basis. I will usually do an ultrasound, confirm the diagnosis, and if time permitting, I would like to do a CT venogram to determine the location of the DVT and also the extent of the DVT, so I know what I'm dealing with when I take the patient to the operating room. When you have the patient in the operating room, there are a number of very important decisions. Where to access. Occasionally, you have to access more than one site to do your intervention. Will I use TPA or no TPA? If the patient is very elderly, the patient had recent surgery, or underlying malignancy, or some kind of cerebral pathology, I'll be less inclined to use TPA during that case. What kind of catheter thrombectomy will I use? There are several catheters that are available on the market and also in each hospital. So I have to make a decision which catheter will I use for the case. Personally, I use AngioJet quite often. So it's something that I'm very comfortable with. So I'm more likely to use the AngioJet thrombectomy system. But in a patient who I cannot use TPA, or TPA is associated with a little higher risk, I will lean toward using another catheter system. Venogram is really central to these cases. It helped make the diagnosis and what kind of intervention is necessary. I will use IVUS when I think there is an underlying stenosis. And there, IVUS is very useful in localizing where the stenosis is. Another important question, after the intervention, does the patient need selective TPA infusion? Certainly if at the conclusion of the intervention, I still see a lot of thrombus in the veins, in the iliac veins, I probably will put a catheter in and infuse the patient TPA for 6 hours, 12 hours, 24 hours, and even up to 24 hours to reduce amount of thrombus load in the veins. And I may take the patient back for a second look. What about brainstem placement? It's very important in these cases, by the time you're done, to have good inflow and good outflow. So in some of these patients, brainstem placement will be very helpful. And finally, this, whether I'm going to hospitalize the patient, discharge the patient. In many of these cases, I have discharged this patient right after the procedure. These procedures, not every case, but many of these routine DVT have become really routine, and I feel quite comfortable sending the patient home right after the procedure. In this case, I access through the small saphenous vein. You can see there's thrombus in the popliteal vein and also in the femoral vein. So usually the strategy to access is in a normal vein downstream below the thrombus. Most of the time, these veins downstream are very distended. So you can access in a small saphenous vein, in a popliteal vein, and maybe even in a calf through a posterior tibial vein. Infrequently, I will access through, from the other side, contralateral approach, up and over, and infrequently I will access from above. So there are several catheter systems that we can use to do the thrombectomy. Penumbra is certainly one of them. It's a system where I will consider in cases where TPA is not suitable or high risk for the patient. You can extract or aspirate the clots into a canister. Angiojet is another thrombectomy system. If you're going to give TPA to the patient, you can use the pulse spray mode to spray the TPA into the clot. You let it sit for a period of time, usually for a routine case for about 20 minutes, or sometimes even longer. And then you come back, and then you use the thrombectomy mode to reduce amount of thrombus in the vein. Here, you look at panel number 1, you see the patient has some thrombus in a common femoral vein, and then the external iliac vein and the common iliac vein are completely thrombosed. I went up more proximally, the vena cava is patent, and the contralateral veins were also patent. So I use Angiojet to first pulse spray the TPA into thrombus. I usually use around 10 milligram, diluted in 50 ml, 100 ml of solution, whatever you decide to use. I usually will let it sit in a clot for about 20 minutes. And then I come back and try to break up the thrombus and aspirate into the catheter using the thrombectomy mode. In this case, I went from the popliteal vein all the way to a common femoral vein, common iliac vein. And you can see this is the completion venogram. It's not perfect. I can tell not all the thrombus were eliminated, removed, but the common femoral vein was patent. So was the external and common iliac vein in this case. So relatively good outcome. And I think this patient will do well, and this patient, in fact, did really well. This is another patient. Here you can see the common iliac vein, external iliac vein, and common femoral vein were all completely thrombosed. Again, you see a fair amount of collateral, suggesting it was an acute on chronic condition. I was able to pass a guide wire through it, and I used the Angiojet thrombectomy system to pulse spray around 10 milligram of TPA into clot. I let it sit for about 20 minutes. I came back and used the thrombectomy mode to reduce the amount of thrombus in the clot. And I also, during this case, I used a balloon catheter to try to press the thrombus against the wall of the vessel. And you can tell in this particular case, there was a very severe stenosis in the common iliac vein. It's very important to keep in mind for the thrombectomy procedure to be successful, you must have good inflow and you must have good outflow. And here, the same patient, I did a venogram from below, and I can see there was severe stenosis in the common femoral vein and the external iliac vein. I felt in this case, I must put a stent in there to have a reasonable chance of success from the thrombectomy procedure. So I went up and over, and I placed a stent in the common femoral vein, external iliac vein, and the common iliac vein. You can see it right there. The stent is really compressed in the external iliac vein and common femoral vein region. And I dilated the stent. And this is the completion venogram. You see restoration of flow through the entire iliac vein on the left side. Occasionally, at the conclusion of the intervention, you see there's still fair amount of thrombus within the vein. And in those cases, I will consider putting an infusion catheter to infuse TPA for some period of time. I usually use 0.5 milligram to 1 milligram TPA per hour. And I may infuse for 6 hours, 12 hours, 24, sometimes even as long as 48 hours. And then depending how the patient does, I will take the patient back for a second look. And in this case, the infusion catheter I put in was an eco infusion catheter. It allows you to get thrombolysis and also augmented with ultrasound. So in these cases with iliofemoral and femoropopliteal DVT, there are a variety of catheters that you can use to do the thrombectomy. You may consider doing angioplasty to press the clots against the wall of the vessel. Occasionally, there may be a need to put a stent in the vein to get a good outcome. And in some of these patients, post-operative TPA infusion will be beneficial to the patient. Thank you.
So Dr. Patel, we have 2 talks for Dr. Patel. Dr. Patel is stuck in an emergency, so Sinai. So we will probably record it and we'll put it in a flash drive for you and give it to you. Yeah, it will be recorded and we'll put it in a flash drive and give it to you. I know you guys were looking forward for deep vein stenting, DVT management. Dr. Ting is here. I'm here. You have any questions? Dr. Krishnan is here. Anybody has questions on venous management?
I usually approach it from an ipsilateral side, from below the blood clot. You see, in that one case, I went up and over from the other side. In that particular case, the stenosis in common femoral vein was pretty low. I felt I would place the stent better by going up and over, so I can put a stent pretty distally, and that's what I did. So usually ipsilateral, occasionally from the contralateral side. That's a great question. What do you do with these collateral veins? You can just leave them alone. And in fact, at the conclusion of the case, you will see marked diminution in number of collaterals from your intervention, and you can tell that you've been successful in reopening the vessel. But also remember, not all the collateral will go away right away. So it may take days, weeks, maybe even months for some of these collateral to completely go away. But you don't need to do anything with the collateral.
How long do you anticoagulate the patient afterwards? Do you do lifelong, or is there a 3 months, 6 months?
If I put a stent in acute DVT case, I would put the patient on anticoagulation for pretty long period of time, at least for 6 months, more likely more than a year or more longer. It also depends on the reason for the DVT. And I think in these patients with acute DVT and an underlying iliac vein stenosis, these are markers for less optimal outcome after the intervention. So because of that, I would put this patient on anticoagulation for a longer period of time. I won't be in a hurry to stop.
Can you just come to the mic if you guys don't mind, please?
Do you routinely oversize the stent in the venous system? And if yes, how much do you oversize?
That is a great question, and there are many different thoughts on how you what size stent you put in these patients. Now, the sizing is a little different for wall stent versus the night node stent. Let me just talk a little bit about wall stent. So in the past, and to some extent even now, I will use an 18 millimeter wall stent in a common iliac vein, and a 16 millimeter wall stent in a female. In the external iliac vein, I almost always will put a smaller stent, put a 16 for both man and woman. So I look at the stent I've used over the years. I'm using less 18 now and almost using 16 for most of my cases. So 16 millimeter wall stent. Now, night node stent, a brave stent, for example, it's one size smaller. So the 16 Abreu is equivalent to 18 wall stent, and the 14 Abreu stent is equivalent to the 16 wall stent. So usually I will use if I'm going to use a night node stent, I will use probably a 14, maybe a 16 if it is in a common iliac vein.
Dan, you want to say something?
Yeah, Dr. Ting. Dr. Ting has such a tremendous experience in doing the deep venous intervention, so I think he'd be a fantastic resource for you guys to ask any questions if you guys have anything further beyond the session. I just wanted to see if you had a couple statements about stenting below the inguinal ligament. You know, I know a lot of people talk about extending the stent down into the common femoral vein. What your thoughts are and some pearls that you need to avoid if you're gonna.
This is another controversial topic in venous stenting. In general, it is permissible to put a stent below the inguinal ligament in the veins. It's not the same as in arterial stents. So having said that, I've been very reluctant to put a stent below the inguinal ligament unless I know for certain the patient will need a stent there. So how do I do this? So I would just keep in mind that you can always go back and put more stent in. But once you put a stent in, you cannot remove it. So I tend to be a little more conservative. So if a patient comes to me and I do a venogram, I see stenosis in common iliac vein, external iliac vein, and maybe something even in the common femoral, I usually will just stent the common iliac vein and external iliac vein. Watch a patient, see how the patient does over time. If the patient continues to have symptoms that I think is from the common femoral vein stenosis, then I will take the patient back and put a stent there. So I don't routinely put a stent across the inguinal ligament in the common femoral vein unless I am certain the patient will benefit from it.
Yeah, I think just the one last caveat to add to that is, you know, when people talk about stenting into the common femoral vein, you're doing that for inflow into the stent, and your major source of inflow from the lower extremity is your profunda vein. So don't cover the profunda vein if you are extending down to that region.
Yeah, so the key thing to remember, these are not life-threatening condition. The patient is not going to lose their leg. You're really improving the quality of life. So you don't have to do everything in one sitting. You're just gonna. It may be a good advice, good strategies. Just gonna do the most important thing in beginning in the first stage and see how the patient does. If the patient really needs it, you can bring the patient back for another intervention. There's some question over there.
What's your strategy on using filters when you're doing those interventions?
Great question. Early on, when I did these DVT cases, I was putting a filter in because I was worried that the procedure, trying to unload the amount of thrombus, some of it will embolize. And I realized after a while it doesn't happen. If it does happen, the amount of the thrombus is really small, and it's really of no, I think, danger or long-term sequela to the patient. The patient will develop symptomatic PE. Usually, it's a major PE. It's a major clot. If you can look at the clot, it's probably tremendous. So when you're dealing with a small thrombus, probably it's not a concern. So, I would say in the last 2-3 years, I stopped putting filter in these patients, and I have not so far encountered a problem.
Yep.
Yeah, this is also for the last speaker and crosses over to you, Dr. Ting. In patients who have these dilated GSV, LSVs and come in, what is your threshold for pursuing a more central venogram strategy? Do we wait for failure of the ablation, crossover venogram, or how do we manage, some of them, they don't have a clot per se, but they have elevated pressure from venous stenosis, maybe Maythorner or something going on more central.
That is a great question. When you see a patient with varicose veins, how often will the patient also have a central venous obstruction at a level of iliac vein? This is a question I'm very interested in. I have been very interested in, and I have looked at many of these patients. I would say it's very common, far more common than is reported than recognized. So how do I know? For many patients, when the patient came to see me for varicose veins, I also did an MR venogram on the patient. And I found the presence of a concurrent iliac vein stenosis, either in common iliac vein or external vein, to be exceedingly common. And so I know these two conditions overlap to a great degree. Now you need to be a little careful in how you approach this. There are many things that you need to consider. One is age of the patient, right? If the patient is a 20-30-year-old woman with a man with varicose veins, I'm not sure you want to stent that patient that quickly. But however, if it is a 50-60-year-old patient and the patient has varicose veins, then you can consider doing an ultrasound and also an MRI, MR venogram at the initial evaluation. Now, and finally, certainly in any patient who you taking care of the varicose veins and the patient continue to be symptomatic, meaning they continue to have edema, pain, aching in their legs, that will be an indication that the patient not only has superficial venous disease, but also have iliac venous disease.